You know, usually when you think about getting a medical test done, there's this expectation of it being a purely passive experience.
Right, yeah.
Like you show up, you give a sample or lie in a scanner, and the machine just, does all the heavy lifting. It feels incredibly routine.
Oh, absolutely. The machinery sort of creates an illusion of complete safety, as if taking a biological photograph carries no inherent risk at all.
Exactly. But the moment you step into the world of urologic diagnostics, well, that illusion totally shatters. Suddenly, simple picture taking or fluid collection is like a high-stakes gauntlet.
Yeah. The stakes are completely different.
And the only thing standing between the patient and a serious complication isn't the calibration of the MRI machine. It's the nurse.
Yep, frontline safeguard.
Welcome to this deep dive.
Oh.
Today, we are looking at the absolute high-stakes reality of urologic diagnostics. We are basically treating our sources like a targeted HESI exam review today.
Which is so needed, honestly.
Right. We're aiming to uncover the critical nursing responsibilities for patient safety and the absolute must-know monitoring steps during and after these procedures. Because whether it is a simple urine cup or, an invasive surgical catheter, the common thread is the nurse acting as the primary physiological safeguard.
So, okay, let's unpack this.
Yeah, and I think for anyone prepping for nursing exams or, frankly, just standing at a patient's bedside, memorizing normal lab values is, well, it's really only the surface layer.
Just the tip of the iceberg.
Exactly. The actual job is understanding the physiological cascade. You have to know the underlying mechanism behind a deviated lab value because that single abnormal number, it completely rewrites the safety protocols for literally every procedure that follows.
The mechanics are what matter most. I mean, before a patient can undergo advanced imaging, or before a surgeon even thinks about an invasive procedure, someone has to establish the baseline kidney function.
Right, you need a starting point, and that starts with non-invasive urine and blood tests. Strict collection protocols here are the first line of patient safety. So let's look at the standard urinalysis and the culture and sensitivity, the CNS.
Oh, the classic CNS.
Yeah. The protocol heavily emphasizes the clean catch or midstream method. And if I'm thinking about the anatomy here, the opening of the urethra naturally harbors bacteria.
Always. It's a non-sterile environment at the exit.
So from a testing perspective, why is it so critical to let the first part of the stream pass before catching the urine? Like, why not just void directly into the cup? It seems like that initial stream is basically acting like a pressure washer.
That is exactly what it's doing. It sweeps all that resident, naturally occurring flora straight off the urethromeatus, and if you don't let it pass, it deposits all of that right into the sterile sample container.
Ah, so you've contaminated the evidence before it even leaves the bathroom.
You've guaranteed a false positive. Catching the urine midstream ensures the sample represents what is actually brewing inside the sterile bladder.
Right, which is what we actually care about.
Exactly. A contaminated sample showing a false positive means the patient might be prescribed, unnecessary potent antibiotic treatments. And broad-spectrum antibiotics carry their own cascade of risks.
Oh, yeah.
From destroying healthy gut flora to promoting antibiotic resistance, all because the initial few drops of urine weren't discarded.
Wow. And getting a pristine sample is really only half the battle. The sources are extremely adamant about sending the specimen to the lab immediately.
Yes. Time is of the essence.
Because urine is chemically active, right? If it just sits on a counter at room temperature, the pH begins to change, which then, alters the rate of bacterial growth.
It completely skews the data.
Yeah. A sample that sits around for 2 hours is telling a completely different biological story than a fresh one.
The environment inside the collection cup must be halted as close to the in vivo state as possible. Prompt lab transport, or, immediate refrigeration that stops that chemical and bacterial clock.
Which brings us perfectly to a test that relies entirely on managing that clock. The 24-hour urine creatinine clearance test.
Oh, this one is a classic HESI stumbling block.
It really is. I like to think of a standard random urine sample as a single photograph. But the 24-hour collection, that's a time-lapse security camera. If you miss even 1 hour of the tape, the entire security investigation is ruined.
That's a great analogy. The clearance calculation relies on knowing the exact volume of urine produced over a precise 24-hour window. The math literally breaks down if the volume is inaccurate.
Right.
And the nursing responsibility that trips up so many test takers is how the clock actually starts.
Yeah, walk us through that.
You have the patient void, and you intentionally throw that very first specimen away.
Wait, really? You discard the evidence to start the timer?
Yes. You note the exact time of that discarded void, and the 24-hour clock starts at 0 at that precise minute. From then on, every single drop goes into the collection jug. And that jug, it has to be kept refrigerated or on ice.
Because if it's not,
Warm urine sitting in a jug for a day will degrade. The creatinine and other components you're trying to measure will literally break down, rendering the final lab value artificially low.
practically speaking, this requires a massive amount of communication, doesn't it?
Oh, absolutely.
Like, you have to post warning signs on the patient's door and directly over the toilet just stating a 24-hour urine test is in progress. Because if an aide or a family member empties a urinal down the drain just out of habit,
The denominator of your clearance calculation is completely destroyed.
wow, and you have to scrap the whole thing and start a brand new 24-hour clock.
Yep. Day 1 starts over. And patient teaching is equally rigorous during this window. They must maintain consistent hydration, but they are strictly forbidden from engaging in vigorous exercise.
Really? No exercise?
None. And they also need to avoid high-protein foods, coffee, tea, and colas.
Okay, this is where understanding the why is crucial for the exam. Vigorous exercise physically breaks down muscle tissue, which artificially spikes the amount of creatinine being excreted, right?
Yeah.
And high-protein diets just flood the system with urea and creatinine precursors. You want to measure their baseline kidney function, not their post-weightlifting, highly caffeinated metabolic spike.
Right. You need the steady state. And you also have to do a thorough drug history, because cephalosporin antibiotics, they can physically interfere with the lab assay used to measure the creatinine.
Skewing the results entirely.
Completely.
Okay, so urine gives us the output, but to see what the kidneys are actually struggling to process inside the body, we have to look at what's building up in the bloodstream.
The gatekeeper blood tests.
Right, BUN and serum creatinine. For exam review, the critical baselines are a normal BUN of 10 to 20 milligrams per deciliter. And normal serum creatinine is 0.6 to 1.2 for adult males and 0.5 to 1.1 for adult females. But these aren't just like arbitrary thresholds.
No, not at all. They represent specific metabolic waste products. BUN, or blood urea nitrogen, is a byproduct of protein breakdown in the liver, whereas creatinine is a direct byproduct of skeletal muscle contraction.
But the trick is that they must be interpreted as a pair to evaluate kidney dysfunction safely.
Yes, never in isolation.
Because BUN can spike independently for reasons completely unrelated to kidney failure, right? Like if a patient is severely dehydrated, has massive burns, or is just eating a pure carnivore diet, their BUN will elevate.
Exactly.
But if their BUN is high and their creatinine is also elevated, that pairing is the definitive siren that the renal filter is failing.
The kidneys are basically no longer clearing the heavy metabolic waste from the blood. It's backing up.
Now, the sources also highlight an emerging alternative, Cystatin C.
Ah, yes.
This requires just a standard 3 mmol blood draw in a lavender top tube with no fasting or prep required. If creatinine is already doing the job, why are we even looking at Cystatin C?
Because creatinine has a major blind spot. It is a byproduct of muscle mass. So think about a frail 85-year-old patient with severe muscle wasting. They will naturally produce very little creatinine.
Oh, I see where this is going.
Right. Their kidneys could be absolutely failing, but their creatinine lab results might look perfectly normal simply because they lack the muscle to generate the waste product in the first place.
Wow, so it's masking the failure.
Exactly. Cystatin C, on the other hand, is a low molecular weight proteinase inhibitor. It's produced by all nucleated cells at a constant, steady rate regardless of muscle mass, age, or diet.
So it provides a much purer, unclouded look at the glomerular filtration rate. If the kidneys are impaired, Cystatin C levels rise predictably.
Every time. And knowing that true unclouded filtration rate is what determines if the patient survives the next phase of diagnostics.
Which is huge because those baseline blood numbers dictate everything that happens in the radiology department.
They're the gatekeepers.
Yeah. If the kidneys are sluggish, if those BUN and creatinine numbers are elevated, the diagnostic imaging could actively push the patient into acute renal failure.
This is that critical transition from passive observation to active physiological risk we talked about.
Let's talk about that radiologic imaging, the stuff that uses iodine-based contrast dye, intravenous pyelograms, the IVPs, and computed tomography, the CT scans.
Right.
The primary nursing checklist before that dye is injected involves verifying iodine allergies, checking for pregnancy, and acting as the absolute gatekeeper for those BUN and creatinine results.
You have to be rigid about it. Contrast dye is hyperosmolar and incredibly viscous. It is a dense, heavy substance that the delicate nephrons in the renal system have to frantically filter out of the blood.
It's like pouring thick, wet cement into a coffee filter.
Oh, that's a brilliant visual.
Yeah. If the filter's healthy, it might manage to push the water through and catch the sludge. But if the coffee filter's already clogged with old grounds, which is basically what an elevated BUN and creatinine indicates, adding wet cement will cause the entire filter to burst or just stop flowing entirely.
The physiological equivalent is contrast-induced nephropathy. The plumbing just shuts down.
But here's where it gets really interesting, especially for patient safety: the elder care crisis.
Yes, this is a massive HESI focus.
Because the aging kidney naturally loses its ability to concentrate urine. When you restrict fluids for these tests by placing the patient on MPO, nothing by mouth for hours beforehand, the elderly patient cannot hold on to their water.
They lose fluid at a much faster rate than a younger adult under the exact same NPO restrictions. So they arrive at the radiology suite already profoundly dehydrated.
And then you combine an already dehydrated system with a kidney that has fewer working nephrons due to age, and then you inject that thick, viscous contrast dye. I mean, the recipe for acute renal failure is baked right into the standard procedure if the nurse isn't actively intervening.
Exactly. Which is why rehydration post-procedure is the mandatory intervention. But the protocol is to carefully rehydrate the elderly patient by encouraging several ounces of oral fluid every 1 to 2 hours rather than blasting them with rapid 4E fluids.
Right. But the monitoring parameters here are fascinating. The sources explicitly mandate monitoring vital signs, urinary output, and lung sounds while pushing these fluids. I mean, I'm trying to clear the slug out of a kidney, so I'm pushing fluids. The urinary output makes complete sense. But checking lung sounds feels like looking for a leak in the basement by inspecting the roof. Why am I listening to their chest?
Because you're dealing with an aging cardiovascular system. The heart might not possess the pumping power to handle the sudden increase in fluid volume you are introducing to save the kidneys.
Oh.
If the heart cannot efficiently pump that knee fluid forward, hydrostatic pressure builds up in the pulmonary vessels.
So the fluid backs up into the lungs.
Exactly. You are listening for crackles, which is the auditory red flag of fluid shifting into the alveoli. The nursing challenge is threading the needle. You must provide enough fluid to flush the nephrotoxic contrast dye out of the kidneys without causing fluid overload that triggers pulmonary edema.
Saving the kidneys without drowning the lungs. That is the definition of a high-stakes balancing act.
It really is. Now, contrast imaging identifies the structural abnormalities, but finding a mass or a blocked vessel requires moving from the scanner to the procedure table.
And the moment we introduce needles and catheters into major vascular areas, the primary threat shifts entirely.
Completely different ballgame.
We are no longer just protecting the kidneys from toxic dye. We are actively protecting the patient from catastrophic hemorrhage.
The monitoring strategy pivots from fluid balance straight to vascular integrity.
So let's examine renal angiography. A catheter is threaded directly through the femoral artery in the groin, pushed all the way up the descending aorta, and maneuvered into the renal artery to assess blood flow using a contrast agent.
You are navigating a major arterial highway here.
Right.
When that procedure ends and the catheter is removed from the femoral artery, the vessel has been breached. The nurse must apply direct manual pressure to that puncture site for 20 uninterrupted minutes.
20 minutes of intense manual pressure, followed by a pressure dressing, and the patient is then restricted to remaining completely flat in bed for 4 to 12 hours, or even more.
Yep, strict bed rest.
During this time, you check vital signs every 15 minutes for the first hour. But the ESI level detail is that you must also check the popliteal and pedal pulses, the pulses behind the knee on the foot, every 15 minutes.
That's a little step.
But again, the puncture's in the groin, and the target was the kidney. Checking the foot seems, completely disconnected from the surgical site.
Well, think about the anatomy. The femoral artery supplies the entire lower extremity. If a blood clot, a thrombus, forms at the puncture site in the groin, or if the artery violently spasms and clamps shut due to the trauma of the catheter, the highway is blocked. Everything downstream of that puncture is suddenly starved of oxygen.
Oh. So the pedal pulse is your distal warning system.
Exactly, yeah. Palpating the foot tells you if arterial blood is successfully making it past the groin. A weak or absent pedal pulse, or a foot that becomes cold and pale, indicates an arterial occlusion.
That makes so much sense.
You are simultaneously watching the groin for external hemorrhage or hematoma and assessing the foot to ensure internal blood flow isn't compromised.
Incredible. Then we have the renal biopsy. A needle is inserted directly through the skin, below the 12th rib, right into the kidney tissue to extract a sample.
Yes.
The patient is awake, under local anesthetic, and actually has to coordinate their breathing, holding their breath, while the needle punctures the organ.
Which is terrifying because the kidney is a phenomenally vascular organ. It receives nearly a quarter of the body's total cardiac output at any given moment. Puncturing it is literally driving a needle into a high-pressure filtration system.
Which makes pre-op safety the ultimate priority. The patient is NPO for 6 to 8 hours. But before the needle ever approaches the skin, the nurse must verify the coagulation studies. PT, BTT, hemoglobin, and hematocrit.
Never skip this.
People often memorize these as a single block of lab values, but they measure fundamentally different mechanisms, right?
Yeah.
PT and PTT are telling us the speed of the clotting cascade. They measure how many seconds it takes for the blood to form a stable clot.
Right. And if the PT or PTT is artificially prolonged, that tiny needle puncture inside the highly vascular kidney will not seal. The patient will literally bleed continuously into their own abdomen.
And hemoglobin and hematocrit measure the actual oxygen carrying capacity and the percentage of red blood cells in the total blood volume.
Exactly. You need a baseline before the procedure so that if those numbers suddenly drop post-op, you know the patient is actively losing blood internally.
So positioning post-op is strictly engineered to prevent that blood loss. The patient is kept prone, flat on their stomach for 30 to 60 minutes with a pressure dressing directly over the flank site.
The weight of their own body provides tamponade to the kidney, it's physical pressure.
After that, they are transitioned to strict bed rest, lying flat on their back for 6 to 24 hours. A critical piece of patient teaching here involves intra-abdominal pressure. They obviously shouldn't do heavy lifting, but they also need to be taught to avoid sudden, forceful actions like sneezing or laughing.
It sounds minor, but a sudden spike in intra-abdominal pressure from a deep cough or a laugh can physically dislodge the fragile internal clot that just formed over the puncture site inside the kidney capsule.
It's that delicate. Naturally, the nursing staff is hypervigilant for signs of hemorrhage. You anticipate a small amount of blood in the urine for the first 24 hours as the tract clears, but the patient must report bright red bleeding or distinct clots immediately.
Absolutely.
Dysuria, or painful urination, and severe flank pain are obvious red flags. But the sources highlight one incredibly specific, seemingly bizarre symptom to watch for: a shoulder ache.
The classic HESI trick question.
I mean, if the kidney is bleeding in the lower back, a shoulder ache makes absolutely no anatomical sense to the patient. Why on earth would a bleeding kidney cause the patient's shoulder to hurt?
It's referred pain. It's a covert sign of internal hemorrhage. If the puncture site fails to clot, blood begins pooling in the retroperitoneal space and the abdominal cavity.
So the blood is just accumulating in the belly.
Yes. And as that pool of blood rises, it physically touches and chemically irritates the diaphragm and the phrenic nerve, which runs from the neck down to the diaphragm.
Oh.
The nervous system misinterprets the origin of that sensory input. The brain reads diaphragmatic irritation as an aching pain in the shoulder.
That is wild. So a patient shifting in bed, complaining that their shoulder hurts after a renal biopsy, isn't just dealing with a stiff neck from lying flat. They are displaying a neurological alarm bell for active internal bleeding.
Exactly. And missing that connection means missing a massive, potentially fatal hemorrhage.
Wow. Now, assuming there are no signs of bleeding and the clot holes, the final safety protocol is aggressive flushing, encouraging 3,000 milliliters of fluid intake to flush the urinary system out.
Right. The sheer volume of fluid acts as a mechanical flush. It pushes residual microclots through the ureters before they can aggregate and cause an obstruction.
While simultaneously keeping the newly traumatized kidney actively processing.
Exactly, keeping the engine running.
Nursing safety in urologic diagnostics really is an unbroken continuum. It begins with flawless, sterile specimen collection, knowing exactly why the midstream catch prevents false positives.
Yep.
It requires acting as the unyielding gatekeeper for baseline BUN and creatinine values, understanding that those numbers dictate whether fragile, elderly kidneys can survive the heavy sludge of contrast dye.
The wet cement.
Right, and it culminates in hypervigilant vascular and hemorrhagic monitoring after invasive procedures, differentiating between an arterial clot in the leg and a bleeding kidney triggering a shoulder ache.
If we connect this to the bigger picture, across all these procedures, the defining characteristic of the nurse is anticipation. When you understand the underlying physiological mechanism, why the aged kidney cannot concentrate urine, or why the phrenic nerve refers pain, you start merely reacting to alarms.
You anticipate the complications before they manifest.
Ex-
Anticipation over reaction. I love that. I want to leave you with a final thought to ponder for your clinical practice, building on the lab values we explored today. We analyze how Cystatin C operates as a constant, pure indicator of kidney function, completely bypassing the massive blind spot of muscle mass that plagues creatinine tests.
Which is so important for the elderly.
Right. So considering how easily an elderly patient with low muscle mass can mask their failing kidneys, and how lethal heavy contrast dyes can be to an impaired renal system, ask yourself, how many cases of contrast-induced acute renal failure could be entirely prevented if healthcare protocols universally adopted Cystatin C as the absolute gold standard for pre-procedure clearance?
It's a huge question.
Think about the lives that single protocol shift could save. Thank you for joining us on this deep dive. Keep that vigilant mindset, remember the mechanisms behind the numbers, and we'll catch you on the next one.